No
But
problem.
welcome everyone. And as you can see there on the screen, my name is Paul Karolidis. I'm out here in Campbellville, Ontario currently. A little bit about myself, about my dental journey. I was a lab technician in '84. I'll try to be brief without digressing into each job, but started apprenticing in the cast partial denture laboratory and then went on to ceramics and metalwork, which I think those jobs are now replaced with the advent of zirconia and CAD-CAM. Became a licensed denturist in '94. Um, and then never really thought of teaching, although was asked to fill in the late '90s when partial dentures became kind of part of our practice here as denturists in Canada. So they asked me as a part-time basis, and then it started from there, and then a full-time position came up, and they said, "Are you interested?" Even though I was embarking on my own professional career, I said, "Sure, it's fun." And where did the time go? I don't know, but I retired from there. And during that time, also had the luxury of becoming an international denturist educator. Special shout out to Mike Vicalis, who started that program for educating denturists abroad. So we were in the US a bit, and the UK, and primarily a lot of students from Europe attending in the UK. So thanks, Mike, for being a visionary and giving me the opportunity with great colleagues like Joey Della Marina and Bill Calais, Carlos Osha, and the list goes on. But it was fun with all of them. So I've really been lucky to have that experience being abroad and sharing ideas and stories and with people pretty much all over the western part of the globe. And it kind of shrunk the world, and everyone's got similar problems and similar education and similar backgrounds. Whether it's technician or denturist, it's all in one the same. Technically, obviously, there was more technical questions with the denture technicians, and then more clinical problems with the denturist. And then through this, now my journey was obviously I was a student and a graduate of George Brown, and then I'll go into it shortly, but then ventured abroad and said I need a little bit more. I'm not feeling comfortable with no slight to our educators, they were good, but there's a time frame and we can't cover everything. So ventured over to Candelar and Zurich and take their course. And actually, I started over first at York, Pennsylvania. I took their course, and guilty of travel myself too. So it was not all work. And then went over to Liechtenstein and took their course. And then in taking some of their courses, they say, "Do you want to be an instructor for our program?" And I said, "Sure, I'm here." Although to date, I've never given any Candelor instructor programs, and nor have I given any BPS instructor programs, but I've filled their qualifications. More importantly, at the bottom here, through the COVID years, I started a YouTube channel, the Denture Adventure, for my students, so they could see the demonstrations going on. And then what I've noticed when I was putting them up there, I put them public, and there's thousands of views from all over, and good dialogue with people, like I said, from all over the planet. Obviously, YouTube's global, and that's been quite interesting. So I post now and then some things. So if you want to peruse that, you go right ahead. And naturally, as Jim said, this will be probably recorded on theirs if you want to come back. So this is what I want to talk about today. This is a class 1 on the right-hand side, or at least my right hand to the side of the screen, which would be the similar as yours. And then a class 2 setup on the left side. And I think what I've noticed in industry and what I'm trying to do today, so you can have a takeaway, because I go to seminars, I go to lectures, I take courses, and I sit there, and sometimes it's on repeat, a lot of the information, but it's always something I can take away. And so if I'm talking to you out there, I'm hoping that you will take something away, at least an idea or an idea to adventure onto another trial of treatment, or something to change your day, or something that could make it easier professionally. So here on the left side, we have a class 2 where the overjet is increased. And over here, we've got the typical class 1 when the overjet's set to a minimum of 1 and 2. What happens when I see an industry, and I'm here trying to bring some ideas of what I see. I go to work tomorrow. I'm at a, now, excuse me, I didn't finish my journey after retiring from George Brown and selling my private practice of 25 to 30 years in that window. I work at a dental office not too far from here from home. So what I see in that dental office is a lot of these cases on the right-hand side that are class 1, which they shouldn't be, because these teeth are way outside the neutral zone. They're way off the ridge, and people are not respecting the limitations that we see here in the patient's mouth here, where everyone's outside the envelope of function here. So what's our first goal? I've got a lot of slides today, so I'm going to try to be brief because I want to get through them all. And I think when you're preparing something, it's like inviting people for dinner. I'm like, oh, this would be nice. This would be a great appetizer. And then what happens is you've just got too much food. So I'm going to try to be quick and succinct and hopefully not get too far off topic, as I tend to do when I see a picture. It reminds me of a story of some kind. So the first half might be a little dry. I'll go through some things that we know all together or where we've been through education. And then the second half will be some cases presentation that I've done, some just recently and some a few years back that I've collected along the way. But our first goal here is patient satisfaction. What does that mean for the patient? That means something different for all patients. Are they a first-time wearer, a second-time wearer, their age, their systemic issues, and what are their expectations, whether this is a partial denture treatment or full denture? Today, we're going to try to concentrate mostly 99% on full denture treatment for these patients. But everyone's satisfaction has a different outcome. Like their expectations need to be met. So from being in denturism a long time, I find the biggest thing, number one, is consultation. We got to spend a lot of time, and I've been guilty of not consulting with the client long enough to delve into the real issues here, rather than saying, yeah, sit down, open up, we'll take impressions. You have to be a little bit more empathic to their own edentulous journey, from dentate to edentalism. And patient satisfaction is the goal. If we can achieve some satisfaction in patient satisfaction, then we'll have some professional satisfaction. And if we have some professional satisfaction, then our spouses will have satisfaction, and our family, our friends, and our pets, and our colleagues, and our staff, and strangers we meet on the street or on the road. So I find that sometimes our professional satisfaction leaks out into our private life. So I hear this from a lot of people, because when we're denturists or technicians, we're working in isolation. And we have no one really to share our angst with when we're at work. And we're pretty much left alone there in the lab, whether we just have a few colleagues next to us and we're trying to move forward with our day. So I think it's important to get out and balance your life from dental technology. The early days, I think we spent hours and days on end in the lab, and 6 days a week, and sometimes 7. It was just nature of the job. But I think in this type of job, we're always trying to find some balance. So here is a picture of Amber Heard. I think she's over the 90% percentile in symmetry. If we use the golden rule of proportion, so her eyes to her eyebrows, to her nose, to her teeth, to her lips, to her cheekbones, zygoma. And there's other illustrations you can find on the internet of, let's say, natural beauty based on proportions. And Da Vinci's Vitruvian Man used this in his Last Supper, Mona Lisa. You can Google Da Vinci, and it's quite fascinating on what they've done, or what he has done artistically. I'm not an art major, and nor am I a math major. But this golden rule of proportion is based on the Fibonacci sequence of numbers. So if you add, if you look at the top right here, 0 plus 1 is 1. And if you add the preceding numbers, 1 plus 1 is 2. 1 plus 2 is 3. 2 plus 3 is 5. So you're always adding the 2 numbers prior to that. And we see this revolving in nature, plants, animals. And this is based on the golden rule proportion of 5, 1.6. And if you divide, let's say 8 by 5, if you look on the bottom right here, 8 by 5 is roughly 1.6, and 13 by 8, which is the next number in the sequence, is 1.6, and 21 by 13 is 1.6. I hope you can follow along, and on and on and on to infinity of these numbers. So this proportion of 5, 1.6, what does that have to do with dentistry and denture aesthetics? Well, obviously, VITA has incorporated this into their master molds when they're coming up with their molds. And I use this off an internet image. If we use the lateral as 1 and the preceding number facially of the visible part of 2, 3, or the canine on the left side is 0.6, then those two added together is 1.6. So you have to have this balance. And this is a natural dentition. And luckily, I've been around from all denture teeth, and I feel very comfortable talking about VITA teeth today because I'm an advent user and abuser of VITA denture teeth. And they're making my job easier and making me look better than I really am. Because I would just consider myself as, let's say, average dental technician, although with above average experience from the years just by default where it's put me. So this is my Amber Heard on the screen. I hope you can chuckle along with me a little bit today. So as you can see, this is a recent flipper on tooth 1-1 or the right central. I don't know the international numbering for American. I think that would be 16, or excuse me, 12? 13, tooth 13, or tooth 1-1 here we would use. So you can see the central. A couple of things I want to take away from this, from what I've started, is the consultation. This is a new denture wearer. She lost her central. Of course, this is not full dentures, but it talks about the consultation. I'm like, sure, you're getting an implant. We'll make you a transitional partial. Here's your central. And this is shade A1. And I think it looks okay. She left in tears and said, there's no way I can go around in public like this. And I went, oh. So I missed the boat on talking to her and telling her what was going to be like, because we're just in haste of replacing her central quickly as she lost it so she can go back to work and in public. And here her expectation wasn't met, sadly. You can see the mesial corner of the 1-1. And this is another point where no matter what I've done, I look at it now and I say, well, that could have been better. You can see the point angle of the mesial and incisal edge of 1-1. That can be better. Maybe it slipped, maybe the burr, maybe who knows. I polished it. I don't know. It was done quickly, but I think it looks fine. She's going to get an implant in 6 to 9 months. But my point here is two things. What we do can always be better if we choose to look at it. Even preparing for today, I went through some past slides. I went, ooh, I made that. Ooh, okay, I'm not going to show that picture. Although at the time, I thought it was fantastic. So maybe that's up to personal growth. We should always look back to go forward. It could always be better. Number 2 is the consult of this patient. Her expectation wasn't met. So since then, though, she's been accustomed to it and she's fine. And what made her fine with this is when she lost it and I had to make another one. And then she realized how great it was versus not having one. Here is my other Amber Heard. And you can see this one, the shade's off. Tooth number 2-2, the lateral here on the right side. Although this patient is doing cartwheels saying, that's fantastic, that's incredible. So we've got one patient that is in complete denial of tooth loss, and this one who's had this tooth missing for quite some time and now it's finally being replaced is like ecstatic. So even though from a technical standpoint, I'm like, it's not that great. So another takeaway from this is generally the patients will accept what we're doing. They don't have another one to compare unless they're getting a new one. But if it's their initial appliance, they're trusting us as technicians and dentures to move forward in the best possible way, and professionals. And they're saying, well, you're the professional, you should know what to do. And then they generally accept it. Now, I go back to working alone, and sometimes you need someone to talk to and say, what do I do here? And I'm going to go through some of those treatments after with the pictures. But what do we know, and where do we seek our information? What do we know? So this is very important. Obviously, school is number one, but school only has a limited time to teach us so many things. And I went to school in the early 80s. Con Ed courses, we're going to get information, something like today, maybe. Our peers, I find, is number one. So back, I was on the Dentures Association of Ontario, and we came up with a perfecting your practice back then, myself and Doug. And we thought that we would get our own membership to lecture to us. We called it Perfecting Your Practice. Plus, that's all we could afford. We couldn't afford outside speakers. So we had all our own peers talking to us. I learned the most from some of those earlier sessions, speaking to colleagues from all around our province that showed up with what they do in their office, their pictures, their waiting rooms, their chair setups, their laboratory setups, and small things from referral pads to lighting. And it was like, yeah, I learned a lot from my friends, because like I said, we're just in one office. We're in one fishbowl, and all we see is the inside of our own fishbowl. It's really nice to share some ideas with our friends. It's difficult though, because in our industry, laboratory or denturism clinics, it's a very protectionist industry where it's like, well, it's like a secret that's going on in there. And people are really, most people, not all, are like, yeah, well, they don't want you to come to the back to see what's going on. Everything is like, it's like Colonel Sanders' special recipe of spices and herbs of what they're putting together. But I'm pretty transparent, and I can show my failures and I can show my successes. So through today, I'll show mostly successes and digress to some failures. But some grad courses are important to get our information as well. But let's agree on one thing today, is the analog workflow. And this is just an average. There's departures of this analog workflow where we would take a preliminary impression with an alginate or a stock tray of some kind, whether it's metal, plastic, a edentulous tray, hopefully, but a preliminary impression of some kind, and then a final impression of some kind. Most people are using PVS today of different viscosities. Back in my time, I was a heavy user of zinc oxide, which I think only one company makes now, and we had polyether and polysulfide rubbers. But generally, PVS, because of their cost and ease, is used today. Bite registrations, in the early days, we would use shellac-based plates. Now it's light-cured base plates, and the waxes have different varieties to choose from. But these occlusion rims that we've been told at school, or in advent of school, we had the Air Force manual, which I'm sure people in the cross border and our side of the border are familiar with, which was a really good resource back in the days. It was pretty much one of the only ones we had to go with, along with Mosby's textbooks. And we would make these occlusion rims 21 for the upper, 18 for the lower. So these things I'm taking for granted, that these basic things, if you're tuning in today, you're aware of. If not, then we can go backwards. So again, I'll take this moment to apologize. Some things might be remedial for some, and some things might be, what's he talking about? So without seeing you or fielding questions live, I'm going to try to throw darts somewhere in the middle and capture everyone. So after the occlusion rims, which is capturing a vertical dimension of occlusion and plane of occlusion and midlines and smile lines and canine lines and even protrusive bite records possibly, and centric relation records, we come up with our wax tooth try-in after tooth selection, insertion, and post-insertion check to see how things are going. So I think we can all agree somewhat this is an average analog workflow of today. Some have been less. I work in the dental laboratory. There's no such thing as custom trays and final impressions. They're saying, here's my alginates, make me dentures. I've also seen no occlusion rims and squash points. I'm not saying these are good practices. I'm just saying what goes on out there. I've also seen at bite registration, we could go further and do pin tracings and like intraoral Gothic arch pin tracers. The impression techniques are done different ways, whether they're border molded, heavy bodies, compounds, are used for the borders. So all different types of techniques, but generally this is, I think we can agree on, is the average, let's say, workflow. So we've got some occlusal schemes to think about now that we've got our workflow in order and the bite registration is taken. And here's what I know of from school. We have the bilateral balanced occlusion, which I think every school and every manual is focused on. Bilateral balanced occlusion or group function, meaning dentures should operate in group function to apply less pressure to the underlying structures and the dentures remain balanced. If the dentures are secure or, let's say, somewhat stable and not moving, then they won't create any friction or heat causing denture sores. The whole idea is to be secure, stable foundation for occlusion. So bilateral balanced occlusion, meaning protrusive, working and balancing contacts in 3 areas at all times. We also have the non-bilateral balanced occlusion, which would be the 0-degree teeth on a flat plane. This back in the 80s became really popular in some dental schools. They would teach their prosthodontic class and say, just order from your laboratories all 0-degree teeth and you will have less adjustments chairside. So these sometimes occlusal schemes are good for the practitioner and maybe not so much for the patient. At least as a technician, it's very obvious when you're using 0-degree teeth if your bite is open or not. So it creates challenges and caveats for both sides. We have the canine guided occlusion, which hope does not exist in dentures, although this would be probably more of an aesthetic result in the anterior region. And most natural dentition would occur with canine guided occlusion. So if you close your mouth, everyone out there, and move your lower jaw left and right, most of you will have canines contacting only in excursions and discluding the posterior teeth. These canines are protecting the posterior teeth in abrasion from left and right excursions. We also have the linear occlusion. Oh, going back to the canine guided, sorry. A lot of people are incorporating this now because with implants as a treatment, securing the dentures, allowing more deflective contacts. I let you decide if that's a good thing or not, but I see that happening with implant supported and implant retained prosthetics. We have the linear occlusion, which I don't see too much, but in my time when I started out, I would see some interesting occlusions where they have this kind of serrated blade, kind of like the slicer that chops, you would see on TV for $29.99 and 3 equal payments. You would chop garlic or onions. You would have this blade embedded into the top part or the lower sometimes, and then occluding against a flat surface on the opposing dentition. So we're going to leave that linear occlusion alone, but I don't see too much of it these days. But there was dental companies, I think maybe I could even say Swiss Dent possibly back then, was making these types of denture teeth. And then we have lingualized occlusion. So on the far left of the screen, we got bilateral balanced occlusion, which is generally 1 tooth to 2 tooth or tooth to marginal ridge occlusion, and lingualized occlusion, which is more of a 1-to-1 occlusion in the posterior section. And I think those are 2 major differences. They both have balancing contacts, they both have working contacts, and obviously protrusive contacts. So what's the fundamental goal of all these occlusions? Why were they all talked about and created and debated? Is because denture occlusion is to stabilize and increase stability in the prosthetics. We do not want the dentures moving. We're talking about tissue and bone supporting the forces of occlusion. And bone heights are different. Muscle attachments from detached and attached mucosa is different. Saliva compositions are different. Systemic health issues are different. Neuromusculature control is different for all patients. And it's a difficult job, maybe. And I think the more we find out about our job, it's harder to move forward with a lot of confidence because it's like, that's not going to work, or that's not. Everything's a compromise, it seems. That's going downhill. I don't mean to be too negative, but there's compromises in most denture treatment, and we need to get the best for our clients. What can we do to give our clients the best fighting chance at denture stability and satisfaction as the first slide was today. So now we go back to school, and I'll try to be quick and not so boring, but there was this guy, Giese, and his working method. This was a marketing genius. Giese goes to York, Pennsylvania, and starts up the True Bite Tooth Company, or which I think was the New York Dental Supply Company going back before my time. And he decides to come up with these True Bite denture form teeth from his research. He's from Switzerland, and he's propagated every dental school and dental technology school, I would believe, in North America. Where back then everybody knew what Bioform 69 was, and 67 and 81, and all the tooth molds of 21J and 21X and 12E. And this was just basic lingo. Somehow this infiltrated our system. He was the first, actually, maybe to give us a foundation. Now, this slide I've taken, and I know this is the VITA lecture, so I'm sorry, Jim, but we're talking about a little history here. But this is the original slide when I was a student that I found in the basement, and I scanned in. And even though when I was a student, this was 20, 30 years old when I was a student. And I'm guessing at the time, but it was definitely older than me. And you can see the square tapering ovoid of aesthetics, phonetics, and function. And our first video on 8mm film was D-Day for Mrs. Jones. And I hope you're having a small chuckle. That's why I wish we were live. I could see you and we could all enjoy this together. And I'm sitting here in isolation. So hopefully you can enjoy this. So, and I can see you, but we'll wait for in live contact. So this is D-Day for Mrs. Jones. And this was the True Bite EPF 20-degree setup in our articulators. And this is what I went to school, and this is what I learned, and I became proficient of porcelain vacuum-fired teeth. And some things about Dr. Giese's thing is his teeth were, let's say, 60% of a natural occlusal table. And the whole idea was to make the table smaller so less things fall off and the balancing would be easier. So you're working in a smaller circle. Now, when I'm showing you these things, I'm not telling you I'm a believer in any of these things, and I'll summate at the end. So there's other people to consider, and I'm not considering one, I'm considering them all. Dr. Giese, let's say, is the grandfather to North American denture education, with D-Day for Mrs. Jones. And if there's enough people out there old like me, you'll have remember that. And then we've got these other, let's say, if we can call them disciples or followers from the University of Bern or University of Zurich, I believe, in Switzerland. We have Dr. Hildebrand, Dr. Gerber from the same city. And then the rest are followers taking from before and altering it later or adding to it. And why am I talking about this today? Because when I went to school, I graduated with D-Day for Mrs. Jones. That didn't help me shortly thereafter. Sure, if I got a class 1 occlusion with lots of vertical dimension and lots of interocclusal space and lots of neutral zone and lots of excellent tissue-bearing surfaces, I could have some success. But you'll see from my case presentations from just recently, there's no merit for that in every case. So I would take from all of these, because I'm always searching, okay, there's got to be something else. We're looking for the Holy Grail. It doesn't exist maybe, but we're searching still. So there's Hildebrand, Gerber, Fairhaller, Schreinermaker, Uhlig, Jude, and Dr. Pleasure, which seems goofy, but that's really, I didn't make it up. That's his name. So I'll go quickly about these, and then I'll go into some case presentations for the day. So we've got before I go there, all of them would have this. Model analysis is standard. So I'm taking this in assumption from our, let's say, whether we're level 1 technician or we've got 30 years experience, or we're students, or we're dentists, or we're denturists. We need to know the anatomy of the incisive papilla, the largus rugae, the muscle attachments, tuberosities, and palatine fovea. And now we decide, with all of this model analysis from experience, where the denture teeth are going to go. Everyone has a different level of atrophy. Everyone has a different level of mucosa support. but this is what we've got to hang our hat on. That's all we have left. And on the lower as well, we've got our lingual frenums, buccal frenums, retromolar pads. We've got Pound's line. We've got this the height of the ridge in the posterior region. And I think we have to really come to some basic conclusions that the lower teeth have to be centered over this ridge. And what happens is when we go outside that envelope of function, or outside the neutral zone, where we start to bring teeth way off the anterior part of the ridge, like that first picture I showed you today with class 2 on the left and class 1 on the right, then we're asking for a lot of trouble for instability of this lower denture. Will there be movement of the denture? Possibly after, but we need to minimize as much, if not eliminate, any movement as possible with these dentures under function. That's our goal. It's sometimes a futile effort. It's an uphill battle, but we need to do that for our clients. Some people will do more, some people do less. You have to challenge your own level of empathy and what you have left to give for your clients or your dentist clients that day, that week, if it changes. I'm just talking about the basic anatomy. I'm going to give it a given that we all have that under control. I'm not going to go back and talk about each part of anatomy. So Gysi's working method, he's this professor in 06, comes out with TMJ movement, and he's saying, hey, there's a relationship between tooth position, the shape of the teeth, and this TMJ and mandibular movement. So he developed this theory. Again, just a theory. And he comes up with these 4 phases of chewing. Number 4 is the most important, I believe, or 3 and 4 in dentures. When the patient closes, we have this hit and slide, unless we are lucky to have this patient coming into a repeatable position in centric relation, where we've created centric occlusion within their centric relation. And we are anticipating, and I remember as a student, my instructor would come by and he goes, oh, you need a check bite. That's a hit and slide. And I'm like, okay, we'll come back 2 seconds later. It's not a hit and slide, or it's a hit and slide from the other side. The patient doesn't have any proprioception of denture teeth. They can't feel through the plastic of where they're closing. Every patient has a different neuromuscular control or elasticity in their muscles of mastication and facial expression. So they need, to quote Mark out there in the West Coast, in I believe Edmonton, freedom in centric. I know he was big talking about this, and I love listening to all of our lectures, and I will use him, quote him, freedom right now, that we need some freedom in closure, freedom in function, freedom under function in phase 3 and 4. Now, where does that have to do with VITA and VITA teeth today? Well, I'm using them specifically because A, I told you they made me look better than I am, technically. B, they give me the freedom to adjust them and shape them in any situation, whether it's extreme class 2, mild class 2, class 1, class 3, crossbite. And I'll show you some of those today. And I can take my trusty handpiece and manipulate the teeth in whatever situation I need. Most of the time successfully, and the odd time, could have done something differently. But I like to dwell on the success as always. So this is Gysi's 4 phases of function. And this is, you can see, I'm not making this. That's right out of 2016 Quintessence, which I think is out of Holman's prosthodontics textbook. So he comes up with the chewing cycle, and he's alerting to everyone, hey, there's a TMJ back there, that the head or neck of the condyle comes down the glenoid fossa, down this condylar path at a certain degree. And I think that has something to do with the patient's protrusive and lateral movements. This is Gysi, and I think we need to do something about that with denture teeth. So he tries to do a simultaneous thing where the denture teeth buccal line angles will work in concert with the condylar path of that degree with the anterior overbite and overjet path. So if you want me to talk about the 5 factors of bilateral balanced occlusion, like the Hanau's-Quint theory, of those things. But we're going to keep it simple today. And Dr. Gysi says, okay, we need some compensating curve, which is curve of speed, in the natural dentition, compensating in dentures. So we've got this kind of mild compensating curve in the posterior region. And this is what we learned at school. But, and again, I'm talking about these is because I want to show, every time I go to take a course, I'm like, well, that's not really the Dr. Gysi's EPF. That's just part of it. And that's not really Dr. Gerber's or Hildebrandt's setup technique. That's just part of it. And then people start hanging their hat on something and say, this is the way I do it. And then from what they do, then I will quietly saying, oh, okay, so you're believing in ABC, or you're taking out D in the recipe because why? It was too much time consumption or it's not needed. And you take out things. Now, if I go back to our analog workflow, we've got dentists and even some denturists, I hope not, taking out steps because why? Well, it takes time. I don't see dentists doing intraoral Gothic arch pin tracing because they're like, no, I'll just grind in any deflective contacts. I don't see, well, that takes time. I don't see them doing Dr. Gysi's EPF where you need an aesthetic control base, a separate occlusion rim, and a separate base plate with the tracers in another one, and using his TrueBite articulator, etc. I don't see us doing that because it seems like the human condition is we want things a little bit faster, things a little bit smoother, things that aren't time consuming. And we look at these setup techniques and theories and we say, well, let's just throw some things away. I can still get good results. So I'm just showing you all of these quickly. And then from them, maybe you'll see, hey, that was Scheinemaker's tray, or that was so-and-so's occlusion rim. So this is our TrueBite articulator, or any Hana articulator, or whatever, or semi-adjustable articulator you want to use, from Cavo to Stratus. So we've got the buccal line angle where the lower model will move protrusively, and we've got balancing contacts here in the buccal line angles, simultaneous with this condylar path. So what do we do if we don't take a protrusive bite record or tracings or face bow? Then this is just average value mounting, right? So we need to have, let me just see if I can go back. I'm sorry. Let me see if I could do something here quickly. Okay, then we got a bit of a pen. So we would generally do this in Bonwell's triangle, which is mount our model, which is the midline of the centrals at 110 degrees 110 millimeters is the average intercondylar distance. Some articulators might be 108, 109, but I think we can agree 110 is Bonwell's theory of the equilateral triangle from the distance of the centrals to the condyles. Intercondylar distance is 110. Whether it be a plain line articulator, like just a hinge, they're 110, unless they're made in Amazon or somewhere. And then when we put these models in this articulator with a face bow, we are going to use this as a average value mounting. And then average value is 30 degrees, which we decided that would be the average human being. And then this 10 degree incisal table. Although it could be 0, and we'll use the anterior teeth and condylar path to deflect this movement. So if you're going to use such an instrument, understand when you're using it for average values, then use the average values. Just don't stick it in because it's not really going to do anything. So we could talk a whole day on this articulator business. But we're back to Gysi's fully functional denture, and the teeth and the condyles should initiate the mandibular movement and reproduce mandibular movement in tooth shapes. And he comes up with these tooth shapes. Position the teeth relative to the mandibular movement. So he develops articulators. His articulator was 33, and his Bennett shift was at 15 average, which we still use today. So you can see that he is the grandfather of some of these average values. And he used this simplex articulator. And we have a little picture from the textbook on the right showing balancing contacts in B, working contacts in A, and protrusive contacts here when the mandible is in protrusion, with buccal cusp tips guiding up the buccal line angles and contacting completely anterior and posterior. Then that would be our group function: balancing, working, and improtrusive. So his is TrueBite Articulator, which I think I took out of some articulator presentation, or you could see in a museum somewhere. And then he has his working instructions. So this is nice, like, hey, all you schools, all you dental schools, all you D-Day for Mrs. Jones, this is what's going on. You're going to take the prelims. You're going to take my custom trays. You're going to use interocclusal registrations. You're going to take vertical dimension of occlusion, vertical dimension at rest, respect the buccal corridor with a aesthetic control base, another occlusion rim, facial contours, midline canine, upper lip lines, a Facebook registration, so we don't have to use an average value mounting in the articulator. A Facebook would be the position of the maxilla of the client in relation to their own condyles, rather than 110, maybe they're 106 or 120. And Dr. Giese says, you got to use interorgothic arch pin tracer to register centric relation and a protrusive bite record to trace these movements, okay? And then we will, some have the pencil on the outside as well. And then we can get CR that's repeatable, rather than how do we get CR now, dentists and dentures. It's like swallow, bite on your back teeth, put your tongue to the roof of your mouth, all these things, trying to get the patient in a repeatable position. That's the idea. So this, I think we can take as basic too, where we got our plane of occlusion, where central and canine are on the plane of occlusion, and the lateral is slightly lifted off. These D-Day for Mrs. Jones pictures of vigorous setup and soft setups are throughout every tooth manufacturer. On the VITA tooth manufacturing side, I find that their ratio of balance between central, lateral, and canine is a lot more harmonious aesthetically to the patient. Like I said, it makes me look really good. If we use the Physiodents and linguiforms, they got like a lot of glass fillers, so the refraction of light is different. In the XLs, again, the fraction of light is different, and gives that a little bit more, let's say, lifelike or real look. So we've got the centrals and canines on the flat plane. This is, let's say, basic setup principles. And this was our education everywhere I've been, including, I forgot that other, my mind is getting polluted with a lot of thoughts at once, but that education program, PT, but they even adopt this, where first and second bicuspid on the plane, first molar mesial buccal cusp 0.5 millimeter, second molar mesial buccal cusp 1 millimeter, 1.5 millimeter for the second molar, second buccal cusp, 1.5 millimeter off the plane. This is just everywhere I go, and like, this is how I set up the teeth. I don't judge, I don't say anything. I'm just looking. I'm like, oh, that sounds like D-Day for Mrs. Jones, Dr. Giese's 20-degree setup thing. It works. It's fine. You got to make sure that this is positioned over the ridge on the other side. And this is assuming that this is average value mounting. This is assuming that the condylar path is at 30. And this is assuming that the overjet and overbite is 1 to 2 millimeters in the anterior, assuming this is class 1. So this is a good foundation, but we need to consider what we've taken away from that. So uppers are set up first, and then the lower anteriors set up second, upper posteriors third, and then the lower first molar first, and then fill in the blanks. This is according to the 1950s EPF. We got Hildebrand, and I'll be quick again. I keep saying that, I'm probably not, but he qualifies the Giese's approach. He goes, no. The mandibular movements are guided only by the musculature. To heck with the TMJ. The muscles will bring the TMJ where it's going to go. We're not going to dislocate it, but he's into the musculature thing. This is it. And we've got step positioning of the molars to aid in the stability of the denture. So he says upper anterior 6, lower, let's put these molars in the deepest part of the mandible, so we don't set up any teeth on the inclined plane. This is Dr. Gerber next, where he takes the same ideas. So are they all different, or are they all just the same with different orders of operation and different small belief systems? I think both are true. They are different, but they're generally lending from each other something. And we need to know when we move forward where we're taking it from. Not Paul on the webinar that day, or I need to know where this stuff comes from. And I'd save you a few air miles today and bringing them here. The results and our goals are the same. We're not changing. Our goals are denture stability. Our goals are patient satisfaction. Our goals are personal satisfaction through our vocation. Please, we have to, unless we're going to devote to the church work or something, for mankind. But there is, there's a capitalistic quotient here in the dental profession. And then what happens is I've even been privy to a lot of school that I've seen, and we've got instructors, and they say, I do it this way, I do it this way, and I do it that way. This is the only way. And I don't say anything. I just say, well, that way's working for you. And then I don't argue and say my way's the best way. Look at me go. Watch me skate. No, I'm saying this is the successes I've had. Share me yours. I'll share you mine. But this is their foundational stuff that they're going. So back to Hildebrand. He says, we don't need compensating curves. We're chop biting. The TMJ is not guiding the functions, the joint values and transfer torque. It's unnecessary to do the face bows and condylar paths. And the setups are done in this occluder of mine, and the guidance takes place on the occlusal field. But now what is really good, though, from Hildebrand, he takes the lingualized occlusion or the mortar and pestle or trough-shaped occlusion, where everything's going to happen on the occlusal table, where we've got the maxillary lingual stamp cusps occluding with the mandibular fossas on the lower, and this is where all the action is to increase overjet. And he says, let's allow for some movements or some freedom, effective chewing movements, so they can operate in this field of occlusion. Okay, thank you, Dr. Hildebrand. And thank you, occluder. I think that's the only picture I could find somewhere. We got Dr. Fair. Now, I'm going to get a little bit hokey as we keep going on, but now he's closer to Giese, and he says occlusion rims are contoured with compensating curves, people, and the rims are modeled so all-around contacts exist in translative movements. So he compensates for Christensen's phenomenon. So when the patient moves in protrusive, all the posterior teeth must be in concert. And this now reminds me back in the 80s where we would get that preformed occlusal rim that was really soft. It was made for Dr. Fair's working method. So this is very soft wax on the occlusion rim surface. Maybe not the whole occlusion rim, but at least the top half, where we could shape these occlusion rims with a compensating curve that corresponds with the patient's condylar path. He says this is very important because when this patient moves in protrusive or left and lateral excursions, we need to mimic these movements in curve of Monson or the sphere of Monson and these compensating curves. So I need wax that's soft. And here is a good picture of this picture here of these wax blocks. And he's also propagating 0-degree teeth. So am I here propagating that here today? Please don't take that away. I'm here with a small, tiny, loose history lesson. That's all this is. So we've got Dr. Fair with the soft wax rims. And he says we need Monson and Spee in this. We've got Holler. He comes out with these molars. All these guys are coming out for denture stability. I'm going to digress, take away from the words, and I'll show you a picture, which is 1,000 words. You can see here, bottom right picture, he sets up 6 and 7, or first and second molar, in this kind of truss roof-like shape. So the opposing dentition locks in 6 and 7, 0-degree, or very little degree, 5 maybe, of this angle. And I'm like, oh, I've never done this. I think some students have done this by mistake, didn't know what they're doing. And I might say, oh, you're doing Holler's molars. That looks really good. They look at me puzzled, say, what's Holler's molar? Oh, it's from this picture from this book I saw once. I've never done that. But this is yet again another theory. I'm not asking you to go out and try it, But keep this in the back of your mind of what people have tried to get the forces of occlusion directed down the long axis of this ridge height right down through to minimize denture movement and increase stability. So there's his angled hollers molars. We got Schreinermaker's working method. He comes out with these trays because he believes, hey, we're going to border mold now. We've got attached and detached mucosa, and the Schreinermaker's working method's all about let's get not only the depth of the flange, I need the width of the flange to create some suction or some muco-gingival seal. He's hollowing out the lingual denture base to increase tongue space. So the tongue naturally kind of expands when people have posterior tooth loss. The cheeks collapse in. So he says, instead of constricting it and having some speech impediments, that maybe we could utilize this tongue to hold the lower denture down. Now that reminds me of a guy over at the college that developed those Mylock wings, Winder Research. And he says, yeah, I got these wings that go under the tongue will hold the lower denture down. I think we did a couple, or we fixed a couple, and it had some merit. And then the idea comes from Schreinermaker. I'm not saying we ripped off any ideas, but it's all about denture stability. What can we do? The sublingual roll has to be replicated. The muscle attachments. So we start border molding with our compounds and our isometric compounds and our heavy bodies, whichever you choose to be efficient at. And he comes up with these plastic edentulous trays. Now, there's a version of these that I use. I don't even know where they're from, but they're very good, that I have in my own practice. You can see here there's some finger rests, which is another idea. They're not just finger rests, but if the patient's instructed to lift their tongue up, then you could replicate this internal oblique or myohyoid ridge area and sublingual fold area by getting their tongue up. Not just if there's no denture there and you say move your tongue to the side, it'll just go over top of the ridge. The tongue has to come up to go over the occlusion. So these two little finger rests would simulate the plane of occlusion. So yet another good idea. So small idea, easy change if you're making a custom tray. Maybe make some finger rests like on the right, or maybe a bit bigger that will simulate an occlusion rim. So if we're going through some muscle movements or muscle border molding, then this would help us replicate those lingual areas. And from our good friend, Dr. Schreinermaker, and then come up with these trays. And this is his working method of custom trays. And he also says, well, we're going to make a border molded impression, but we're going to use a closed mouth impression with vigorous cheek borders and action limit. So now when you take courses, then you can say which ones are which ones are propagating closed mouth impressions. So now, at least when we hear things, we know where they come from, right? If we hear a name, we know what movie it's from. Or if we hear something, we know what history book it's from. I think it's important. And what happens is people just move forward and like, well, you need to know where it's coming from. So then you need to know, what parts of everything that you're using. I find it important anyway. So here we got with the post-dam Schreinermaker. He says, we're going to start scribing. Now, back in our day, my God, I don't even know got that old. But back a while ago, we were put the post-dam in. But I think we're compensating more for our deformation in dental materials, right? Our alginates and our silicones or our polysulfide rubbers and our single phase or dual phase polymerization, where we had more shrinkage during polymerization, our split cast. But now we have milling denture bases. Now we have injection molding denture bases. We have more stable acrylics, I would think. So we don't have to, let's say, compensate as much in the posterior palate area. This is a contentious area, though. You read the textbook, I finished my denture 2 millimeters anterior to the palatine fovea, which I have. I finished before them. I've even finished on them. And crazy, I finished way past them onto the soft palate. And I found I'm experimenting. I'm not any of these guys in their study, but I'm experimenting. Like, the further back I got a lot of retention. Or sometimes I made a lower denture and I got suction. Did I get it by accident or did I do something different? So, was my border molding better? Was it the quality of saliva? And the whole idea I want to know is so when I'm diagnosing the client, I can tell them what's going to happen. I'm not reacting to them what is happening. So if you can front end load to the dentist or the patient, this is what's going to happen because of this, you're a genius. And that, I think, is back to say the holy grail that we're trying to chase, or that I am, is saying, how can I forecast the future from this clinical situation they have? And then their experience will be exactly how I told them it would be, rather than an excuse for what they're feeling. And I think that's different, how it's perceived. If your prognosis is poor and you tell them why, and it is poor, and you've pulled out all the stops, it's more accepted. I hate that to happen, but sometimes prognosis is very poor. So again, I digress on Schreinermaker's trays. So Schreinermaker says, let's set the front teeth up with aesthetics and the lower posteriors set on the ridge. I'm just checking my time. I've got enough time here. So he says, these lower teeth got to go on the ridge. Well, that seems like all the way back to Giese. That goes all the way back to any school. That goes back to the Air Force manual. That goes back to anything I've read overseas or here. It seems like we're all in belief here. That's a good idea. Now we've got these two guys, Oleg and Jude. I'll be really quickly. So when I see an old denture come in with a suction palate recessed in the palate, they're trying to get this suction effect as saliva is the promoter here, where the border mold is margins act as the valve and the cheeks are the outer valve, hollowing out the palate and the vibrating line for retentibate. And you've seen these maybe that come across for denture repair. You go, ooh, is that ever old? Okay, it's not vulcanite old, like that kind of old, but it's like, oh, that's interesting. Look at that. Or it's a cast palate with a recessed hole in it. Okay, not good for the tissue. If you see inside the patient's mouth, they've got this big edematous red area, but they're foregoing the tissue management for suction. I can't say I've experimented with it, although I've witnessed it in many denture repairs. So this is where it comes from. This is Horst. And he's saying we're going to do it when the tissues are more hyperplastic. So then now you got to go to, let's say, a mucostatic impression, and that's where our zinc oxides and light bodies come into place. We're going to border mold. Patients got bony ridges too. All kinds of things going on here with Oleg. And we're going to border mold. But most takeaway here is I want compensating curves as well. So he's taking away the basics as well. I want those. And then Jude says, I'm going to do the same. I'm going to muscle mold, and I'm going to make a custom tray, but I'm going to add this little wing on the back here, because this is helping me go past this mandibular tubercle or the retromolar pad area where my denture occlusion past that's going to finish. And these will aid in retention. Have I put these wings on like this? Personally, no, but I've encroached this area with the dentures successfully and unsuccessfully. And sometimes aiding in better lower denture adhesion. We've got the last one, Dr. Pleasure. I know, goofy name. And I just took one picture off the internet here, 6 and 7. If we look at this first and second molar, the first molar is sloping towards the buccal, where the buccal cusps are lower than the lingual, and reverse curve of SPE on the number 7, where the second molar, where the lingual cusps are lower than the buccal. And he's doing this kind of curve of Monson crossbite or SPE Mons crossbite, where these it would aid in denture stability. Now we get to the class 2 situation. Okay, let's see what I've done here. We've got 5 real, or I believe there to be only 5 ways that you can approach a class 2 denture occlusion. You can take some posterior teeth and grind them. Ivoclar used to many moons ago make a T-type mold. where the lingual cusp of the first upper bicuspid was flat. This was okay, assuming that the class 2 was the same amount of overjet for every case, and that doesn't exist. We can talk anywhere between 4 millimeters up to 14 millimeters of overjet. It's extreme. And I'll show you some of mine coming up here. So this doesn't work. Lingualized occlusion, of course, would work. And these VITA teeth I'm talking about that I use specifically, the linguiform, I can grind, and they can be used both ways. In class 1, meaning one tooth to two tooth relationship, or lingual cusp in the distal fossa in a lingualized occlusion, one tooth to one tooth, slightly offset from on top of each other. You could also use for a class 2 a 0-degree occlusion with compensating curves. So this one I would leave to chance, I guess, for when we're not sure of how much overjet we're going to have. So sometimes it's easier in the laboratory setting. It's like, I'm just going to put 0 and let the dentist move some things back and forth if we have the right aesthetic limitations in the anterior. And lastly, when it's an extreme class 2 overbite div 2 division 2, where the lower anteriors are biting on the palate of the maxilla, like a division 2, then we'll use an anterior bite plane on the palate, where the patient is actually biting with the lower teeth on the rugae area. So I'll start with my patient C. Yeah, okay. Maybe if you had a little nap over my digressions of history of education of denture occlusion, now's a good time to wake up and saying, what is this guy actually doing out there? So in comes my my Amber Heard. Yeah, I don't even know that girl. I don't know why I used her. I guess she was in the slide. So in comes my patient C here. She's got a full upper denture against the natural lower. You can see in this picture, that's 110% overbite of these porcelain vacuum fired anterior teeth that this patient's been wearing for 25 years plus. I'm just estimating. I don't have it written down exactly. And this is her denture in situation right now. And she comes in, and this is a social services client that I agreed to do X amount of social services cases per month in our local community because of its cost effectiveness, but I have no problem helping out our community. And great gal comes in like this, and she says, I don't like these dentures. They just don't stay in my mouth. And I really don't like the looks of them. I said, so how long have you had them? Well, you haven't liked your look for 25 years or something? My goodness. But she's, whether for whatever reason she didn't seek out other treatment or she thought this was it, but she got used to these. So that goes back to our earlier point where the patient will get accustomed to anything we do, whether it's iatrogenic or not, they will. But we need to be a little bit more, let's say, cognizant and aware of what we're doing to our clients' underlying tissues. Sometimes I've even told some students, they said, so what did you want to be now in denture? Like, what do you want to do in dentures? And I said, I want to be sometimes the person that made the first denture that has no idea what happened and they're not accountable. Sometimes that's easy because most of the clients that we see, they don't come for hello. They come when they got a problem. And when they got a problem, okay, now I have to fix it. And now I got to fix someone else's problem that he's created the problem worse, or she. So now I've got this 110% overbite. And I'm going to tell you, I have no idea what I'm going to do. I have no idea. I look at the lower, I'm like, wow, look at 6 and 7, music migrated. She's missing a bicuspid there. And this is her denture. You can see the inverse slope of anterior teeth. You can see that they're trying like hell to get to a class 1. These porcelain teeth can't be ground, so they're up against the ridge, I'm assuming. And it looks like they dropped the bicuspid. And the patient's biting pretty much, I think there was a hole through the back of one of the sides here, distal side of 6. And there's the front picture of the, and now, okay, here I'm incoming. I don't know what I'm going to do. Doesn't matter, 10, 20, 30 years of experience. I'm like, I've never done this denture for her before. So I'm going to go with what I learned from D-Day for Mrs. Jones and onwards. I'm going to make an occlusion rim. I'm going to make the occlusion rim an average value of 22, and I might go higher or lower. You can see this one still is not this nice 10 degree that we learned, this anterior section. Like most of the time we'll make our bite block like this at 10 degrees like our rulers are cut out to, but I just went straight down. I knew I was going to be way out anyways. But I'm going to mark the midline and the smile. I still don't know what I was going to do. Mounted it on my articulator in average value mounting. I didn't take a face pump. You can see the attrition that the porcelain has done here to the lower teeth. My goodness. You can see that they're filed down the whole anterior four. Maybe this is a better picture of the natural dentition here. Sorry, that kind of doubled over that little slide there. And she's missing a second molar on one side and a second bicuspid on the other. And I think I'm just taking pictures because I don't know what to do. So I said, let me just take some pictures. I don't know. And sometimes I just do that because I don't know. I'm not a photographer. I'm not going to use this at school. I don't teach anymore. So I'll just take a picture. It's only on your phone these days. It's so easy. So I mark the incisive papilla. I look at the largest rugae. I know from a lot of experience that the anterior tooth is going to probably fall right in here, this area here. And then we've learned from many denture setup courses, this could be anywhere between I don't know, I'll just make it up as I go, 2 to 7 millimeters anterior to this incisive papilla. This is our neutral zone. I haven't seen anyone function without the orbicularis or the mus facies of expression dislodging the upper denture. I haven't seen that. People operating way out there. So I know that's where that tooth is going to go. I don't know how much overjet that is. I just poke it through. And this is my version of base plates. I don't cover the ridge with my base plate. I just cover the palate. Why? Because most of the time I'm grinding teeth and I don't want the base plate to accommodate the setup. The patient's not buying a base plate. They want aesthetics. So I want to maximize my tooth contour. That might go against some of you base plate makers out there in the labs. I'm sorry, but it's just in my way. And what do I need it for? Just to stabilize my rim. Okay, I'm a good enough practitioner that I'm not going to leave it in there for an hour for it to melt. I could even take the 3 registrations if I need. So also with my wax, I can engage undercuts rather than block the undercuts. I would risk ruining my master model that I painstakingly took half-hour border molding and pouring and trimming and whatever. And now I'm going to ruin it with a $2 base plate. This is not a good thing. So I'm going to use wax in the undercuts if there are any. And if there's too much undercut and the patient feels discomfort at the bite registration, which I need the occlusion rim stable at the bite registration, I can relieve it. So there's my overjet. I didn't measure. I don't have her old one to go by. Looks like 8 millimeters overjet, maybe 9. And I still don't know what's going to happen here, but you can see from that measurement from this, I'm pretty much right about the inside of the land area of those anterior section. That seems to be a 95% average of anterior tooth location. I'm not saying the patients like it there, because some patients want you to do some real magical things like Botox with their upper lip, or their lower teeth have over-erupted so much. I want to show more teeth. I'm like, you can't show more teeth because your lower teeth are taking the whole aesthetic window because they've over-erupted and you didn't reline the existing one. So now it's too late to get these lower teeth unless you increase vertical dimension, and now they can't talk. So I hope you followed my chain of thoughts there. So here I am adjusting the denture teeth. Physiodens, whether it's MFT or linguiform, not physiodens, the MFT or linguiform, the first bicuspid has a longer buccal cusp to it. But these teeth are versatile for partial dentures, which I find that longer buccal cusp comes in super handy in cast partial denture situations where I need it, where I'm taking the lingual part off. So here I'm adjusting my occlusion. It looks like it's trapped, that lingual cusp, but it's not. I'll show you in a future picture. I'm setting up, and there we have, I dropped the bicuspid. You can see here my occlusion is here, and this lingual cusp is ground down. These here, and then the 7s are pretty much in regular occlusion from the side here. So I've ground down the lingual cusp and come to some type of reverse class 1 end-to-end on number 7 or second molar. Still have no confidence what's going to happen here. You can see the occlusion here. And I'm checking working. I'm checking balancing. I can't put anything in further because there is no room here. I guess in hindsight, now I'm looking at it, I could have used the same bicuspid mold, but a larger molar mold, which might have brought me to here. Maybe I could have. Like I say, it could always be better. And I could do some incisal grinding here a little bit if I don't want to take these customized angles. And this is the wax try-in. And I'm crossing my fingers. I can't stress that enough. I'm going into centric occlusion and then balancing, working, taking any deflective contacts or trying futile. It's futile because the teeth are at different occlusal heights. And now I'm trying to get a harmonious, balanced contact going back and forth as best I can. And here's our working, and that's just denture dust there. That's not the tooth grinding. And there's our wax try-in. And there is our finished product coming up here. You can see the attrition of the lower teeth. And this turned out 10 times better than I ever thought it did. And she's extremely happy. It's not exactly occluding on the wet line down here, maybe, but I had to make room for protrusive. People with class 2 have an ability to move their mandible more than other people in a protrusive movement, up to 10, 12 millimeters, to come in contact in a class 1 and then bring back food to chew in the posterior section. So I got a good 5 or 10 minutes left, and I'm going to move on to a few more patients. Patient D, I called her, comes in like this. I hope you can all relate, dental technicians and dentures. This canine is out, so it's a canine guided occlusion. You can see from the wear, this tells a story. Extreme overbite that the patients wore down in here. There's 90% overbite again. I go through the same routine. Bite block, 7 millimeters, the land area. And I'm like, she's got lower natural teeth of 4, like canines in first bicuspids. And now I've got this overjet here. It is what it is, so to speak. Not trying to sound cliche, but that's what it's going to be. I'm going to heavily consult with the patient. This is why. And you'll see that this is in centric occlusion or centric relation record in centric occlusion, and they can move forward. And this is the end result. And I'm checking all deflective contacts. And I think at the end, she wanted a diamond. I don't know if it was real or not. If it was real, that's kind of big. But she wanted it inside the canine, so I recessed the canine and put the diamond in. And probably more securely because I would be responsible if that falls out. But interesting stuff. But you can see I think these are her natural 2 teeth here and her natural 2 teeth here, canine and bicuspid. Oh, excuse me, one more over. She's got 4 denture teeth in the lower. Anyways, we got patient E. Oh, relate with this one now. And this is, I'm like, okay, Paul, there's the patient, whatever, up to, we're making an immediate denture. I'm like, there's a reason why dentists allow dentures to exist. Is because they don't want to do this. I'm like, what am I going to do here? That is her centric occlusion right now, natural dentition. This is, and those are my blue lines going, I think we're going to have to shorten these chipmunk bonded composite centrals, recess the uppers up and back because they're way out, and consult with the patient. I need to open the bite slightly. In an immediate denture, you got to tread carefully because now the patient is going from their own teeth to biting on plastic. This is our biggest litigious cases in denturism and dentistry. Is patients wake up from an aesthetic and they go, what did you do to me? I didn't expect this. So there needs to be a lot of consult on what to expect. So here's my centric relation record with my rim. And there's the teeth that I've selected here for the case A3. And these teeth in the posterior, I'm going to grind down for what I need them to be. In the posterior, I've extracted my central. I put my central in. I think it's important when you're doing immediate dentures, dental technicians, and I've had them work in my laboratories. I go there and all the teeth are off the model. I say, where are the teeth? Oh, over there. It's an immediate. They're gone. Keep some, please. I need to know where we were so I know where we're going. because now you've taken away all the information. So I'm going to do left side and then right side. So you can see where they were. And I'm measuring the tooth. I'm picking this mold from this halo of the CEJ, and I'm putting it in location. I think that looks about right. And retracting, but still with slight class 2. Slight in the central. There's 1, 2, 3. And there's our setup. She did not want the diastema to match the lower here. Close the space. I'm still crossing my fingers. And crossbite over here, because these have gone way outside the buccal corridor for the uppers. Plus, this is going to help me aid in denture stability. If we go back to some of the earlier guys talked to today, setting up in crossbite. Not that I'm a big advocate of it, but in this case, it's going to help minimize the dislodgement of this upper denture. And there's the finished product. Unfortunately, only one, but she was happy. She put lipstick on for the event. We've got patient F. A few more minutes. This is my occlusion rims in class 2. Standard issue, 30 degrees up here in the top right, it looks like. So basic average value mounting. Anterior teeth in the envelope of function, in the aesthetic zone, not outside the aesthetic zone. The lower teeth on the ridge, no further than the outside of the lower ridge. And that's the overjet that we're going to have. Now I have to clear that overjet in protrusive movement with the average condylar distance. It's nicer if I took a protrusive record to get the exact protrusive condylar distance, then I could match the compensating curve. But I'm staying, from experience, I'm getting very close. So minimal adjustments. So here's my left lateral, and you can see I'm clearing this. They will just barely contact when I'm in a lateral excursion to the left. I don't want any deflective contacts. And there's the lowers on the ridge. I did not go outside here on the bottom, outside the ridge. Do not go off there. This is straight down the middle. VITA teeth, if we take a setup course with VITA, these will be set in a straight line. They make it easy for us, which lines up the central fossa, unlike other tooth companies. A lot of denture setups, they put the, I see a lot of people with the canine incisal line angle lined up with the central fossa. This is the biggest error. This is the most critical area in aesthetics, is the movement from canine, the corner of the mouth, to the posterior. The transition from a 3-lobed tooth to a 4-lobed tooth, if we're talking histologically. This is very critical in aesthetics. The angle of these canines is critical. Are they straight up and down? Are they laid off? Right? I hope they're not in reverse, the canines, in line angles. In a more specific denture setup program, we can talk more individually of the line angles of the teeth. And what I'm talking about is this here. Here is the overjet, our class 2. You can see I've hand ground the lingual of 4. I'm into a half a class 1 here, a lot of overjet here still, and then a lingualized on number 7. We got all occlusions going on at once. Our finished, I don't know what happened here, Paul. I hope that's straight. And then we've got patient M. A few more minutes. Crossbite, just to go quickly into the crossbite, that we've got less than 80 degrees, where the upper ridge is smaller inside the lower rim. So here's patient M without teeth. And I'm like, great. There's no one here at school to help me now. I'm by myself. I'm like, I better take some good impressions here. I got some silicone in the back, border molded impressions. I take my occlusion rims, my VDO, my VDR, my CR, midline. Not even sure the midline here. It looks like I had a shaky Parkinson day. I got a couple here, but I found it. And then I put the teeth in their neutral zone, or the aesthetic window. And I had to forego some buccal corridor here and went down the line. The lowers are on the ridge, and I needed crossbite in the back. So here I've got a slight minor class 2 in the anterior with crossbite in the posterior. And I didn't know that going in 100%. And this turned out fantastic. Retention, stability, aesthetics. Okay, we've got some modiolus issues here, but for stability, I'll forego that big smile. That's the most she smiled. And I can even individuate this with my VITA accent. staining, if you choose to go a little bit further in your customization of your dentures, in your denture-based tooth colors. And there she is, finished. She was smiling more than I've ever seen her smile. Last one, really quickly. This job, this is the takeaway, which I don't even have to tell you. Of course, it's a difficult task. Of course, it's a difficult job, because I've got the lady coming in here with this broken bridge, 3 teeth left, and she goes, I want to look like here when I met my sweetheart. This was my smile. But I look like this now. I'm like, oh boy. Immediate denture too. So how much trying can I do? It's a class 2, and the patient is, this is this div 2 where look at the contact over here. Look at, there's no contact over here. Not until we get to 7, and the patient is occluding on the palate. It worked. I had to get out of my way, so to speak, to do it, because I'm like, this is not D-Day for Mrs. Jones. This is not Amber Bird. So I leave it as a thank you. And I hope you took away something from my own angst and dental journey for today. So thanks, Jim. I'm just assuming everyone's out there with me still.
Yeah, thanks, Paul. That was a great presentation. Let me go over a few things, and then we're going to go ahead and talk about the Q&A that we have. Any questions? So I'm going to take the screen back. All right. So those of you that are on the phone that or that have reached out through the question box, the CE is going to be there within a week or so, if you will. It has been recorded. Will give us about a week. We'll post it on the VITA North America YouTube channel. There's a bunch of other videos as well that you can go and contact in context with different information that you can review and look at as well. If you need to get a hold of one of the VITA reps or us internally, please do so. Here's the information. And then we have future courses and future webinars coming up. And July 24th, 25th, we've got Paul scheduled for a 2-day denture hands-on workshop. So if you're interested, please contact our education department, marketing department. But that'll be in Brea here at our new facility at the VITA Academy. Again, July 24th, 25th. It's a Friday, Saturday course. But Paul, I appreciate you accommodating us on the new dates, and we will get this full. We've got a maximum of only 12 people, so please get your registration in early, and we'll give you a chair and participate in this exciting denture course that we're going to have with Paul. So please let us know if you're interested. And then Paul's been gracious enough to, here's his information, contact information. So if you have any follow-up questions, here's his phone number and his email address. But please recognize that he's traveling, he's doing other lectures, he's training his students at George Brown College and so forth. Very busy guy, and then doing his own work. So give him some time to respond, if you will. All right, so as far as the questions go, so Q&A, several of them. After you grind the teeth, do you polish the teeth?
Good question. Both. Sometimes I'll do it before, like with the rubber point, and then actually I'm going to polish it after in the final processing. But most of it I do with the rubber point, especially if I'm using the linguiform or physiodents because of the glass content in it. So I will use a rubber point to polish it and then high luster it at the process. Good question.
All right. And then do you know why the industry really went away from porcelain teeth?
I think because of the versatility of it. I'm just guessing now. Maybe the process is very labor intensive, the brittleness, The fractures, I think we're just getting they're harder, so you're putting a lot of pressure down on the underlying structures. And I think we're not increasing the VDO just vicariously anymore. That we need space, right, for porcelain teeth, for those retentive pins, as well as the bonding between porcelain and plastic is not as good as composite to plastic or plastic filler to plastic. So you're going to get those dark micro leakage of staining around the porcelain teeth. So I just think the products are better. And I think with the advent, I've used that word a lot today, with the addition of the processes of the glass fillers or the nano fillers in the PMMAs now are just that much better in the manufacturing of the teeth.
All right. Do you ever set up the posteriors first?
Of the upper? No. Of the lower? No. I would always work in the anterior section because I need to know that relationship, and then the rest just fills in. Lowers on the ridge, and the upper posteriors would be the last thing. But that's just me personally. If other people, many people, would do it differently, and they find it works for them, works for me. Probably from repetition as well as some successes.
And if you don't have enough room in the posterior to put both your molars, what tooth do you drop?
4. Is we talking full upper, full lower?
Yeah, let's just
drop them all. I've even dropped them on the floor and can't find them.
The bicuspid, do you just not set up the first?
Yeah, I would eliminate the number 4 because the occlusal table on number 5 is bigger, and I believe that if the patient has a larger table to work on, then I have more freedom to give them freedom to work on number 5 occlusally.
Okay. Is there a maximum anteriorly, a maximum you can go beyond the papilla?
I would stay inside the land area, and depending, the papilla is usually constant in location in atrophy. It's not moving. It can be mobile, left and right, but very slightly. I would just stay within the land area, and that's generally between 2 and 7, 8, maybe. And when you go outside that land area, I think that's when you're looking for trouble.
And then you went over a lot of occlusal concepts, but in reality, is there one that generally works best, or a combination?
I think that's what people, let's say, in the beginning would say, okay, just stop it and tell me which one's best. I think we have to take principles away of denture stability from all of them, but obviously the grandfather of Gerber's, lingualized, and Gysi and Hildebrand, those 3 are the pretty much basic foundations, right? And so from that, I was hoping everyone could synthesize all those and see what we do today in an analog workflow. So we're border molding. We're trying to get the attached versus detached mucosa. We're trying to get the right length of dentures. We're trying to get the right adhesion of dentures. We're trying to get the teeth in the neutral zone, and we're trying to make dentures stable. We're not doing crazy holler setup molars or anything like that. That was more of a FYI of what people have been trying to do with this dilemma. So maybe I'm not answering directly which one's the best, but we need balanced occlusion, not just 3 points, as many as we can in all excursions with no deflective context, with proper denture extensions and proper teeth in the neutral zone. Whether you call it one person or all 7 or 8 or 10, those things are the takeaway.
And kind of a follow-up question, beyond the, in the U.S. anyway, the U.S. Air Force manual, is there a manual or a book that would kind of go over all of this for some of those folks that are not trained as well as others?
There's a lot of information, obviously, with the internet, and I think one of your own, Urban,
Dennis Urban, or Christian Urban,
Sakinen.
Christian Urban, yes.
He was in the International Denturist program, and he synthesized some good information, which is available on your website, believe it or not, in the denture setup guide. And there, I've used it, I've downloaded, I've given it to students. I think you've even made a small little, I don't know, I got this at some show. It looks like a little calendar size setup manual, but it is a smaller version of what's online. You can download that, and there's nothing in there that's obtrusive. Like there's nothing in there to be like, oh my God, this is a heretic. It's actually very good.
And if you, any of those listening, if you need a copy, electronic copy, you can always get a hold of us at the help at VITANorthAmerica.com, and I'll be glad to send you the information.
Yeah. I even think it's a free download. I think it's a free download on maybe the international site. I'm not sure.
Yeah, they
Yeah.
yeah, if anybody has a hard time finding it online, but
Yeah.
yes, it is on the website, VITA North America website. I'll link to it. Yes,
That's a good start,
PDF.
I'd say, because that is a really culmination of really good basic information.
And then another question regarding the type of setup. Do you primarily go for a balanced functional setup, or is it
Always.
the case itself dictates what's needed?
Even though those extreme few cases I showed at the end are, believe it or not, stable in excursion. So yeah, I'm always always striving for balanced occlusion.
All
In
right.
protrusive, I tend to really lean on the protrusive more than sometimes the left and right. Obviously, depending on the patient. I had one more to show where the patient had a stroke, so they're favoring one side, but we'll leave that for another time. But yeah, and even that will be, even crossbite is balanced. Yeah.
All right. Nice. Well, thank you, Paul, for taking the time to deliver some excellent education
Yeah.
for traditional dentures. I know there's comments also that they were very pleased to see that we're continuing to do some education with traditional, that not everything's gone digital. We know it's
Well, the
closely in that
information,
way, but
yeah, the information would be transplanted digitally. So you
yep.
still need to have those ideas that we just talked about today in front of the monitor. It's the same. It's just a digital wax instead of analog wax. So,
Yep.
but yeah,
But
thanks for having me. And I hope my number one message is I just hope someone can take away and stay on the journey that you're on, and try to get better for yourself and your patients. And myself, after so many years, I feel like I just started. But I think it's coming to an end. I don't know where the time went, but I'm always trying to, for whatever reason, if it's innate, trying to get better one year after the other. It just seems to always just
well,
reaching for the next thing.
we got you scheduled out here for July 24th, 25th in Brea, California. Those of you that are interested, please get a hold of us. It'll be a great 2-day denture workshop where we're going to do both class 1 and class 2 setups. And we'll have you bringing in articulated models that we'll provide you, and then we'll go over all this stuff, these things, these in detail, the different concepts, and start from scratch and let everybody set up and wax and learn more. So I
Excellent.
appreciate you scheduling that.
Yeah, I look forward to that and meeting yet another great 12 colleagues in the future. It's awesome.
And I want to thank everybody for joining us today. Again, if give us a week or so for CE and for the videotape to go online at the VITA North America YouTube channel. But I want to thank everybody for joining us today. I hope everyone has a great day wherever you may be. And Paul, we'll see you again in the near future.
Excellent.
And thank you very much again. But this will end today's webinar with Paul Karolitis. Thank you.
Right on. Thanks, guys. Take care.